Good evening, web shadowers. Thank you all for attending our session tonight. We have the pleasure of hosting Dr. Mbwana, who will be presenting on child neurology.
And as always, please remember that the Google form will be posted in the chat box at the end. With that being said, Dr. Mbwana, you may start whenever you're ready.
Great. Thank you guys so much for this opportunity. I apologize that we had to reschedule from earlier in the day. Thank you for being so flexible. I know everybody's time is really precious, and so thank you for everyone who came by. So just to give a bit of an outline, I always like to give everyone an idea of what I'm going to talk about. I'll give you a really brief background about myself. I'll talk a bit about child neurology and what the field entails in case there's anybody out there who may be interested in child neurology. We'll go through a case and at the end of the case, we'll review some quick teaching points, my own teaching points from the case. And lastly, we'll go through any questions that you have. And my intention for this is to kind of do it as close as possible to like a shadowing kind of experience. It's my first time to sort of do it in this way with the YouTube live. I will try to monitor questions that may be coming up on the chat box. But if you've typed in any questions and you think I completely haven't answered it or have ignored it, I think one of the moderators, you can just let me know to make sure that we're efficient, but I also get through people's questions. All right, so we'll go ahead and start. Just wanted to put some bit of disclaimers there. I saw someone else did this in their presentation. I think it's important. You know, this is all done for education. The cases that I'll discuss are fictional and not based on anything real. And I'm doing this in my private capacity and not on behalf of any institution. So the views and everything are just mine. And of course, there's no financial incentive. We do this because we love teaching. All right, so just a brief background about me. Again, I'm Dr. Mbwana. My journey into medicine started in college at Yale University. So shout out to Connecticut, New Haven, Connecticut, where I did biomedical engineering. And I loved that as my undergrad major. If you get time at the end, I can talk your ears off about how that's been crucial to my training as a physician. And I went to medical school down south in Atlanta, the Morehouse School of Medicine. So shout out Atlanta, Georgia, which was a really great experience. It was about that point when I realized that I did want to do not only pediatrics, but pediatric neurology. I followed that. I went back to Yale to do my pediatrics residency. That's 3 years. And then after that, I moved to Philadelphia to do my child neurology fellowship at the Children's Hospital of Philadelphia. So that was another 3 years. Following that, so this is about 4 years ago, I started working at my current job. So I'm a child neurology attending at Children's National Hospital in Washington, D.C. It's a pretty large freestanding children's hospital with multiple divisions. And with that employment, I'm also an assistant professor of neurology and pediatrics at the George Washington School of Medicine. Now, when we're talking about child neurology, which a lot of people also call pediatric neurology, we're talking about any disorders of the brain, spinal cord, peripheral nerve, or muscles affecting infants, children, and adolescents. We treat patients all the way from the moment of birth all the way up until 21. Actually, I see patients until they graduate college. And so if, I see some 23-year-olds, and often with people have certain conditions, we'll even see them until they're 30 or 40 years old. So we span that whole frame. To become a child neurologist, the training that you would need is following medical school. You would have to do 2 years of pediatrics. That's 1 year short of the standard pediatric residency, which is 3 years. So you would do 2 years within a program, and then you would have to do 1 year of adult neurology. And after that 1 year of adult neurology, you then do 2 years of specialized child neurology. It's important to know that when you're thinking of this process, most training programs currently include all 5 years at a single institution. And therefore, in medical school, you would be applying for a 5-year program that would include the pediatrics, adult neurology, as well as the child neurology. Child neurologists get board certification through the American Board of Psychiatry and Neurology. And so that's one sort of important thing to know that differentiates us from many of the pediatric specialties. We do not go through the American Board of Pediatrics, and our certification is in neurology with special qualifications in child neurology. So we really are a subspecialty of neurology and not a subspecialty of pediatrics. And as a matter of fact, a child neurologist is trained and board certified to treat anybody, including adults. We just choose to treat children because we prefer that. And some child neurologists will also get board certification through the American Board of Pediatrics because you are eligible to do it, although many won't because you technically don't need that to be employed or to work as a child neurologist. Some common conditions that we see in child neurology, I kind of split them up by what we see in the clinic in an outpatient setting, as well as what we see in an inpatient setting. So headaches are very, very common. Seizures and epilepsy, probably that's number 2 as far as what we see. We see concussions. Important to note, some of these things like headaches and concussions can be managed by pediatricians, but if they get a bit complex, then they're referred to a child neurologist. We see children for tics and Tourette syndrome. We see children for all manner of developmental disorders, cerebral palsy, ADHD, certain neuromuscular problems. On the inpatient side, some of the things that we deal with are strokes. And yes, children do get strokes at all ages. Any sort of infection, inflammation, or autoimmune conditions affecting the nervous system, multiple sclerosis, which is actually an autoimmune condition, congenital malformations, certain genetic conditions. And this list is by no means complete. This is just an example of common things that we see that I thought of off the top of my head. So we're going to go through a case, and how I've structured this is, let's imagine that you as a pre-med, because I believe this is mostly for the pre-meds, you're shadowing me, and I'm currently working in the hospital as the neurology consult attending, and we're called to the emergency department because they have a 15-year-old girl who fell down the stairs at home that afternoon. So it's actually evening, a time like now. So what are a couple of things that you think could have caused the fall? Why would a neurologist be consulted for a fall down the stairs? I understand that there's a small delay with the chat discussion, so I'll kind of give a brief minute. Anything that you think of, go ahead and type it before I tell you, sort of kind of give you the answer. So I see one person said trauma, so that's a really good one. A trauma certainly that can cause you to fall, can be the cause of your fall, can be the result of a fall. Concussion, definitely. Seizure, yep, like I said, seizure is something that we see very commonly. I see lightheadedness, definitely. Many people putting in the common, I'll say the most common things I'm seeing coming across the chat are concussion, seizure, head injury, nerve damage. All those are really good. So what I tend to do, not just for myself, but anytime I'm working with any trainee, so if it's a resident, a fellow, or even a medical student, I like to come up with a list of possible things even before going to see the patient. It kind of gives you a good frame of reference as to what questions you'll ask and what things to look for. So for a 15-year-old girl who fell down stairs at home, we're going to go through a differential diagnosis for a fall. And I think if you've had a couple of these sessions, you're probably familiar with the term. Differential diagnosis. That's basically a list of what is possible. So that's my list right there, which goes with some of what people have mentioned. Seizures and epilepsy at the top of the list. You know, we get called about that all the time in neurology. Syncope, which is the medical term simplified for fainting, is another reason. Vertigo or dizziness, that's another reason why someone may have a fall. You could also have some weakness due to some underlying condition, whether it's acute or chronic, that causes you to fall. And of course, there's always sort of the last thing, which is a mechanical fall. You just kind of tripped over your legs. All those are possibilities. So this is sort of gives us that frame of mind, even before we've gone to see the patient in the emergency department. We kind of have a brief list over there of what may have resulted in the fall. What I'd like to do is to talk briefly about two of the more common conditions, seizure, epilepsy, as well as syncope, so that we're all kind of on the same page about what to consider or what to ask when we actually do go down to the emergency department to see this patient. So when talking about seizures and epilepsy, it's important to know primarily the definitions of what is what. When we're talking about a seizure, that's the clinical expression of abnormal excessive synchronous discharges of neurons, or what I tell parents is abnormal electrical brainwave activity. It's important to note that we all have electrical brainwave activity. That's how the different parts of the brain communicate. But if anything happens to disrupt that normal flow of electricity within the brain, that's when you get the clinical seizures, clinical features of a seizure. A seizure is a symptom, kind of like a sneeze or a cough, whereas epilepsy is a condition. So epilepsy is a condition in which someone has had or is at risk of having seizures due to some lasting derangement of normal brain function. And on the image right on the left, of course, you have the brain right there, and you have an EEG, which is a measure of the electrical brainwave activity. And then you have what you would see on the EEG if someone's having a seizure. So you see that this normal pattern has been interrupted, and it's almost, some people use terms like electrical storm, or some will say it's like a forest fire in the brain happening for a short time. But that's really important, again, to remember when you're talking to someone, what you mean when you say seizure and what you mean when you say epilepsy. So there are a couple of diagnostic clues or things that would make you think someone may have had a seizure when you're taking the history. One of them is a loss of awareness that's sudden, just kind of comes just like that, because when you have this abnormal brainwave activity, it's not something that comes up gradually. It's kind of like just pops out of the blue. And so there's no sense it's going to happen. Someone will be doing something, next thing they know, they're waking up on the ground. There's typically some increased or decreased muscle tone. Some people will have that increased muscle tone and stiffness where they're either kind of flexed like that or extended out like that. They may have abnormal movements, but that does not always happen. And the abnormal movements are usually rhythmic, and so happening in some kind of manner like that. Or you might have some abnormal movement of the lips or sometimes even the fingers, but you do have that with many, but not all seizures. There's often some form of alteration of mental status after the event, and that's because when your normal electrical brainwave pattern has been disrupted, kind of takes a bit of a while to reset. So many people have a seizure. Following that, when they wake up, they're kind of confused, kind of tired, and that may last anywhere from a couple of minutes to a couple of hours. And certainly, a history of prior similar events. Someone who has seizures or someone who has epilepsy, they tend to have the exact same thing happen each time. And so if you get a history of multiple falls where each time someone was stiff, that's probably a seizure. One of our best diagnostic tools is the EEG, electroencephalogram, and that's what you see right here, which again is that measure of the electrical brainwave activity. If anyone has any further questions about seizures and epilepsy, I'm going to move on to the slide for syncope, but feel free to continue asking questions as we go along. All right, now talking about syncope or fainting. So syncope is sudden brief loss of consciousness associated with the loss of postural tone. And so kind of classically, as someone who's standing or doing something and all of a sudden, next thing you know, they're on the ground. There's a couple of different things that can cause syncope. The most common one is what we call vasovagal syncope. And that's basically when something happens that causes your heart to, sometimes you say skip a beat, but basically you're not getting enough blood to your brain. And common sort of examples of that is some people, they'll see blood and all of a sudden they'll faint, or they'll be in extreme pain and they'll faint, or they get really worried and faint. So all those would be under a vasovagal syncope. You can have orthostatic hypotension. So hypotension meaning low blood pressure, orthostatic meaning dependent on position. So this is when some people, especially if they're dehydrated, when they go from a sitting position and all of a sudden stand and they kind of lose color, and next thing you know, they're on the ground. That's slightly different than orthostatic intolerance, because we tend to think of orthostatic hypotension as being something that is transient, like, you didn't drink enough water today and so you get it and it happens. Whereas orthostatic intolerance is something that kind of is more long-term, more chronic. Certainly for some people, it's toxic exposure, getting some kind of drugs or chemicals makes them faint, or if you have a cardiac condition. I'm just gonna go talk about seizures really quick. Somebody is asking, is there a difference between seizures while awake or while asleep? No, there's no difference between seizures while awake or while asleep. They can happen anytime. They do occur more commonly when you're asleep, but ultimately a seizure is a seizure. Whether you're awake, asleep, or in between, as long as it kind of meets the criteria, we would include that there. Question about syncope is whether narcolepsy would be included under syncope. Technically, no. Narcolepsy is a thing on its own. When I was coming up with a differential diagnosis list for falls, I considered putting narcolepsy there, but I purposefully didn't. I didn't want to put too much, but narcolepsy, which is a sleep disorder that can cause you to basically suddenly fall asleep, it's different, and we would not consider that a part of syncope. Right. The question, what if you faint after seeing blood, what can you do to overcome that? So as a neurologist, very seriously, what we tell people, number one, is avoid looking at blood. Basically, avoid the situation that causes you to have the vasovagal syncope. Usually for people who are having multiple syncopal episodes, they'll also see a cardiologist, which I would recommend as a neurologist, to make sure that it really isn't a cardiac condition that makes you keep having this repetitively. But other than that, you want to avoid the stimuli that can lead to you having the fainting spell. I'm gonna kind of, again, go, to answer the questions, I'm gonna go a bit back and forth. Somebody is asking about epilepsy. How long do symptoms last if one is diagnosed with epilepsy? So it really depends. Epilepsy is a whole discussion on its own. You can actually talk for 5 hours about epilepsy and still have a lot to talk about. There are very many different epilepsy syndromes, some of which, when people have them, they'll really only have seizures that are very easy to control, and they might only have them a couple of times until they're put on medicine. There's some where they're lifelong conditions, and so it depends on the epilepsy syndrome that someone may have. And no, seizures technically do not cause damage to the brain. Most seizures last 3 minutes or less and stop on their own, and in those cases do not cause damage to the brain. The biggest risk for having seizures is if you fall and injure yourself, or if you have a prolonged seizure, meaning you have a seizure lasting longer than 15 minutes, or classically an hour or two, which happens, that can lead to damage to the brain. But most seizures that people have do not cause damage to the brain. Sorry, and if seizures go unnoticed in those scenarios, just a single seizure, again, the biggest risk is physical injury that they may get from falling, and not necessarily from the seizure itself. What I'll do, if you guys don't mind, there are a lot of questions coming in for seizures, but I want to continue moving on with the presentation. So I may jump back and talk a bit more about seizures at the appropriate point in the presentation. So now jumping back to syncope or fainting, some of the diagnostic clues is that, again, there's a loss of awareness, but it tends to be more gradual. And someone has a sense that something is happening. And those could include the prodrome symptoms of dizziness or lightheadedness or vision abnormality. Things kind of look like they're blacking out. And so fainting less commonly happens suddenly. Someone will say, oh, I feel lightheaded. Next thing you know, they're on the ground. And you have decreased muscle tone with fainting or syncope. You typically don't have any kind of stiffness. It's more so, someone is really down and out. And important diagnostic tools include vital signs, getting the heart rate and blood pressure, and sometimes you do orthostatic vital signs, meaning you check these when you check the heart rate and blood pressure when someone is laying down flat, when they're sitting upright, and then when they stand up to see if there's a difference between those. And then very importantly, we do an EKG, which is a record of the electrical activity of the heart to see if a heart problem may have caused the fainting. And in most cases, we'll also do blood work to look and see, is there an electrolyte imbalance? Have they been exposed to any kind of toxic substances that can cause the fainting? So those are things that might help you differentiate if this was syncope versus something else. All right, so we're gonna now go see the patient in the emergency department. We've had a good review of seizures. We've had a good review of syncope. What are a couple of questions that we can start asking this patient to clue us in to what the cause could be? And what I'll do is I'll start while I'm waiting for the chat to catch up. I'll just kind of mention a couple of questions that I'd ask. I'd want to know about the family history. Is there a history in the family of other people who've had any kind of seizures or syncope? That's a really important question. You want to know about the past medical history. Does this person already have known conditions that could cause them to fall? A known heart condition, a known seizure condition. So those are important things. What else? You also want to know, in pediatrics, we do a social history. We like to know, is the person in school? If so, what grade level? And are they performing at that grade level? Who lives at home? Those are important in kind of building your case. All right, so a couple of questions people are asking, and I'll give you the answers since I know the case. Question is, did you trip over anything? No, she did not. And what happened before you fell? She was actually just walking downstairs and all of a sudden a leg sort of gave in and she fell. Is this the first time? Yes, this is the first time that she had a fall such as this. Does she have any pain? No, she does not have any pain at all currently. Has she been sick in the past day or two? No, she has not. She's been feeling like just her normal self. Drinking or drug history, she does not drink any alcohol and does not use any illicit substances. As I mentioned, she does not have any current medical conditions. And yes, she does remember her fall distinctly. She remembers starting to walk down the stairs, and next thing she knows, she fell down. She did not lose consciousness, and she remembers her parents running in as soon as they heard her fall. Does she have trouble maintaining balance? No, she does not. Was it really hot outside today? No, it wasn't. Let's just say she's in Washington, D.C. right now, and today was a pretty chilly day. Not as cold as up north, but it was cold. Any current medications? No, this girl is not on any medications. Did she feel lightheaded before the fall? No, she did not. She just really felt like her legs just buckled all of a sudden. Has she traveled lately to different countries? No, she hasn't. Unfortunately, she had plans to go to Mexico, but with the coronavirus pandemic has not gone anywhere for the past couple of months. And does she remember tripping or feeling lightheaded? She doesn't distinctly remember tripping over her own feet or over anything, but just remembers the fall. And she did not feel lightheaded. Question of, does she have depression? No, she does not. She does not have any medical, psychological, or psychiatric conditions. Did she drink enough water? She thinks so, and her parents say she drinks several bottles of water a day and is pretty healthy. Anxiety? No, she does not have any anxiety. So I'm going to go ahead and just click, and so we can see some of the questions that have been asked. And so in summary, she woke up in her usual state of health, no problems at all. She was actually working out on her stationary a bicycle. That's just her way of getting exercise. And then that's when she started walking downstairs. And next thing she knew, she fell. No loss of consciousness, no symptoms before, no loss of muscle tone. Her parents, who came as soon as it happened, said she didn't have any abnormal movements. And afterwards, of course, she was confused as to why she fell, but seemed to really be with it. And the past medical history, family history, and social history are all non-contributory. And so that was a really great history that we took. Let's go ahead and examine the patient, another crucial step. So her vital signs are completely normal. Blood pressure, heart rate, all normal. And moving on to her exam, the general exam, which is heart, lungs, and all of that, that was completely normal. The neurological exam, we typically start with the mental status, and hers was completely normal. Memory was intact, concentration, and all of that. And her cranial nerves, so the nerves involved in movement and sensation of the face, were all intact. That's very important for us to know as neurologists. She had 5 out of 5 strength, and so we have a gradation system for strength, and 5 out of 5 means she had complete strength with no weakness when we tested her. She had appropriate muscle tone, and her sensory exam, so looking at light touch, temperature, vibration, proprioception, which is position, as well as pinprick, which is pain, were all completely intact. And she had appropriate coordination, balance, and gait. So a good summary of this would be, of her exam, was that it was a completely normal exam with completely normal vital signs, and she had this fall that we talked about. So now we're going to go back to this differential diagnosis that we came up with for a fall. We talked about seizure and epilepsy, syncope, vertigo, weakness, or a mechanical fall, all as being possibilities as to why she fell. So let's go through them one by one. So we've seen the patient, we've gotten that history, and now, as we commonly do when we're shadowing in a medical setting, is we step out of the patient's room so we can discuss as a team what we think. So based off of the history that we have, as well as the exam, what is the possibility that this is seizure? So in looking at the chat, I'll keep an eye on that. And let's also think, what is the possibility that this is syncope? What is the possibility that this was due to vertigo? What's the possibility it was due to weakness? And what's the possibility that it was a mechanical fall? I should note that the mechanical fall for us as neurologists would be what we call a diagnosis of exclusion, meaning you ruled out a problem with any of the other systems. And unless she said that she tripped over something, we have to rule out a problem with any of the other systems before we fall back on this was a mechanical fall. All right, so I see a couple of people saying low, minimal, zero possibility, low, low. I'm just gonna say, for the sake of it, I think probably saying low possibility to seizures and epilepsy, and I agree. There was no sort of abnormal movement, no loss of tone, and she remembers the whole thing. I see, a bunch of no's, which I think also no for syncope or fainting. She didn't have any prodromal symptoms, and we also know her vital signs here were normal, so kind of no risk factors for that. She remembers the whole thing, so probably not fainting. What about vertigo? So it sort of depends. If this was vertigo, she would have said that she had dizziness at that moment, but she didn't. At the same time, if it was a condition that causes vertigo, she would have had some prior history of dizziness. So I'm going to say it's probably not vertigo. What about weakness due to nervous system dysfunction? Is there something that could tell us that it was not due to weakness? I'll actually put up my attending hat on and say that, to play it safe, there's nothing here that tells us that it's not due to weakness. Yes, her neurological exam was normal, but we can't conclusively say this was not due to weakness. mechanical fall stays on the list, but as I mentioned, a mechanical fall is a diagnosis of exclusion. And so what we're sort of left with right now is we first have to assess and make sure that the fall is not due to any sort of weakness before we can, go back and say that it was a mechanical fall. I see a couple of people saying that mechanical fall is most likely. And what I will mention, I'm sure you've heard, in medicine when we talk about, what is it? Horses and zebras, that when you hear hoof beats, it's most likely a horse because horses are more common, especially here in North America. And so you think it's a horse and not a zebra, but occasionally it'll be a zebra, which is something rare and unexpected. So in this case, a mechanical fall would be the horse. That is most likely. Weakness due to nervous system dysfunction is zebra. Not as likely, but it's possible. But as neurologists, we're just going to do a good job and kind of make sure that's not it. So what I'm going to do is now we're going to talk a bit about weakness to kind of go through that to put us all again in the correct frame of mind. So when we're talking about weakness, and there I'm showing a leg muscle. So most people, when you're thinking about weakness, you think of it as a problem of the muscle, right? Your muscles are what you use to sort of push back, to contract, to kind of basically give you strength. But as neurologists, one of the really important things that we like to do is called localize the lesion, which means you think of any possible part of the neurological system that is involved with a particular function and seeing which parts may have a problem that would lead you to having some sort of dysfunction. And so for weakness, for a problem where the endpoint is the muscle is not able to do what is required, let's think about what is the origin of the signal. That origin is the brain. And you can see in this picture, they've labeled some of the different lobes of the brain, including the motor cortex right there. So the motor cortex is where you generate the signal to move. Your frontal lobe might be what helps you with the decision of, let's move, let's run, let's walk. But then your motor cortex is what actually sends that signal and says, move your leg in such a manner or contract the muscle. It's not a direct pathway though. It's not that it jumps from the brain to the muscle. From the brain, the signal gets sent to the spinal cord. So you have the signal generated right there and kind of goes through different parts of the brain down to the spinal cord along the pathway to get to the muscle. So basically you can have a problem here or here that leads to weakness in general. From the spinal cord, you have your peripheral nerves. So the peripheral nerves are the nerves that come off of the spinal cord and to the muscles or different organ systems in the body. So now you have your signal was generated in the brain. It's traveled to the spinal cord. From the spinal cord, it's going to the peripheral nerve, not yet at the muscle. Before it gets to the muscle, it has to get to the neuromuscular junction. So the neuromuscular junction is kind of the synapse or the connection between the nervous system and the muscular system because they kind of use different ways to sort of send along the signal. So here in the neuromuscular junction in this diagram, you kind of see that's a nerve that's coming and joining the muscle, and there's that connection right there where you basically have a chemical reaction that happens on the surface of the nerve, and that chemical reaction causes you to release a substance called acetylcholine, and the acetylcholine travels and lands on the surface of the muscle. It lands actually more specifically on what we call the acetylcholine receptor, the thing that receives it. And so it lands on that. And once it lands, that generates the signal to the muscle to contract or to move. And so you have that sort of system right there, the neuromuscular junction. And so once you're there, now then that completes the pathway. And so for you to be able to move a part of your body, the signal has to go like that. Starts from the brain, spinal cord, peripheral nerve, neuromuscular junction to the muscle. So as neurologists, when we think in general about someone having weakness, we want to localize the lesion. We want to, based on the exam, the history, as well as any testing we'll do, determine, are they having a problem in the brain, the spinal cord, peripheral nerve, the neuromuscular junction, or is the problem really in the muscle itself? So we're going to go through those in a bit of detail. So we have our diagram of the brain here. What are a couple of different causes? So not even thinking specifically about this case where a 15-year-old girl fell, but in general, what are different things in the brain that can cause you to fall? I'll just go ahead and name a couple. So you can have a stroke, you can have a tumor in your brain, you can have sinus thrombosis, which is basically your blood, some vessels in your brain kind of get clogged up. You can have vascular dissection, and so this is blood vessels leading to your brain that kind of split and open up. You can have a condition called acute disseminated encephalomyelitis. We just call it ADEM, and that just means part of your brain where you have what we call the white matter is having some breakdown. Multiple sclerosis. ADEM and multiple sclerosis are both autoimmune conditions. You can have infection, which would be meningitis, that can cause it. You can have a problem with the blood vessels, inflammation called vasculitis. I see some people put down trauma. Yes, you're right. Trauma should be on that list. I see actually very bright. Katie said cerebellum loss of balance. I had actually neglected to put that. That's true. You can have a problem in your cerebellum so that what you have is a loss of balance that causes you to fall. Cerebral hemorrhage, you can certainly have that. Basically, there are many things that can go on in the brain that causes someone to fall or have weakness in general. Some of the clues that would let you know that that's what happened is focal weakness. So if one part of your brain has any one of these, and we call, stroke, tumor, ADEM, multiple sclerosis, all those, they give you what we call a brain lesion. A lesion just means an area of abnormality. So if you have a focal lesion in one part of the brain, the weakness that you have is most likely going to be limited to just one side of the body, or just maybe a single arm or a single leg. So that's a very important clue. You can also have what we call upper motor neuron signs, especially if this has been going on for a while. That means you'll have increased reflexes when you check them, and you'll have increased muscle tone, some kind of stiffness. Our best diagnostic tools is brain imaging. You basically want to take a good picture of the brain, whether it's a head CT in a more emergency situation or an MRI as well. I see someone else said transient ischemic attack. You're right. I should have said stroke / transient ischemic attack because they're similar. Both involve decreased blood supply to the brain. And someone else said hypoxia, so decreased oxygenation to the brain. All those are really good things to think about. So those are brain causes of weakness. How about spinal cord causes? So many of the things that we mentioned for the brain, you can have similar things to the spine that'll cause weakness. So again, I'm gonna pull up some spinal causes, spinal cord causes of weakness right here. So you can have a stroke within your spine. You can have a tumor within your spine. You can have trauma, especially if it's like a really bad trauma, you can actually transect and basically cut your spine. You can have transverse myelitis, which basically, again, is breakdown of certain parts of your spine. ADEM, neuromyelitis optica, those are autoimmune conditions kind of on the spectrum or similar to multiple sclerosis in a way. You can have infection of the spine. You can also have acute flaccid myelitis, which is something that's been in the news lately, which right now there's no very great known cause. We know it's associated with certain viruses like enteroviruses, but sometimes people can have basically spinal lesions in the setting of an enterovirus that can give you distinct weakness. Someone said hernias. Yes, you can have hernias. I'd put hernia on sort of on the same sort of line as tumor or mass. Basically, you have something that's compressing different parts of the spine, causing that weakness. Oh, this is great. Someone put calcium deficiency. So it's true. You can have a deficiency of certain vitamins that affect the communication line in the spinal cord that can give you weakness. So great. I love this. People are coming up with things that I didn't even think about. Maybe it's because I know the case, but I love this sort of thought process that everybody is going through. Diagnostic tools that we have, again, similar to a brain problem, focal weakness, depending on the size of the lesion, might be focal where it's just the lower body, not the upper body. Could be focal where it's just like one arm or one leg. And again, you're gonna have upper motor neuron signs as with brain lesions. We can do, all right, I said brain imaging, I meant spine imaging as a diagnostic tool. And then you can also do a nerve conduction study where you're basically assessing the function, not of the spinal cord, but of the nerves to determine if there's a problem that the nerve basically wasn't getting a signal already. And sometimes depending on what our thought process is, if we're suspecting an autoimmune condition, we can do a lumbar puncture to get cerebrospinal fluid to analyze. Someone's asking, could scoliosis impact spinal cord function? Not in most cases. Most people who have a milder scoliosis that's identified and managed appropriately by an orthopedic surgeon will not get any spinal trauma, but in severe cases, I can see how it can cause compression and cause you to have that. Moving along to peripheral nerve causes. So we've gotten out of what we call the central nervous system, which is the brain and the spine, and now we're in the peripheral nerve. What problems in the peripheral nervous system can cause weakness? So I put a couple over there. You can have what we call demyelinating neuropathies, and that means you're having a breakdown of one of the coatings of the nerve. It can either be acute, happening just sort of abruptly, what we call acute inflammatory demyelinating neuropathy, also known as Guillain-Barré syndrome. It can be more chronic, and we call that chronic inflammatory demyelinating syndrome. And that can happen in very many settings. Happens sometimes in the setting of someone who is extremely ill from something else, being in the ICU for a long time, but it can happen, it can happen just sort of on its own. You can have an infectious neuropathy, so infection being the primary cause of breakdown of your peripheral nervous system. And there are also certain hereditary motor sensory neuropathies. The most common one is Charcot-Marie Tooth. So basically it's a genetic issue from the time you were born where your nervous system is not able to send signals appropriately. Somebody said, let's see what else we have, restless leg syndrome. So that's really not going to give you a true weakness. It might give you a sensation that you feel like it's weak and it's not really a problem with the nervous system that's causing you to move the legs and have the weakness, so not as likely. So someone else is asking diabetes. So diabetes can give you a neuropathy. So a neuropathy means your peripheral nerve's not working well. In many cases, what diabetes gives you is a sensory neuropathy. So you think about the peripheral nervous system as having two components, the motor component, which is involved in movement, which is what we're thinking about with weakness, and then your sensory component, which is involved in sensation. And pretty much for the sensory component, that whole pathway that I did from the brain downwards, sort of reverse it. You know, it's going to go from your nerves to your spine all the way up to your brain. And so you more commonly get a sensory neuropathy with diabetes. And clues would be symmetric weakness. And so because typically this is something that affects all the nerves in your body, all these conditions, or at least it affects them in segments, weakness is usually symmetric. If it's legs, it's both legs. If it's arms, it's both arms. And you have what we call lower motor neuron signs. And so decreased reflexes and decreased tone. Diagnostic tools would be a nerve conduction study or a lumbar puncture. I see several people asking whether or not this could be ASL. So in the setting of this presentation, not likely, and at least for this presentation, I won't go too much into it, primarily because we tend to think of that as adult neurology condition and not a child neurology condition. I should say most of everything that I'm doing is looking at it from the pediatric standpoint, and so I'm kind of for now ignoring conditions that we see more in adults than in kids. All right, I'm gonna move just slightly faster because I think I wanna make sure we have enough time for questions towards the end. So now, what about the neuromuscular junction causes? As you recall, I mentioned what happens is you have your synaptic vesicles on the nerve side of it. You release acetylcholine, which comes into this cleft right over here. Acetylcholine lands on the acetylcholine receptor that initiates the movement process here. And a third component, another component I didn't mention, is you have a chemical called acetylcholinesterase that breaks down the acetylcholine. If the acetylcholine that you release from your vesicles just stayed on your receptor and just stayed there, you would basically not be able to move, right? Because you would just kind of stiffen up. But what happens is kind of right after that, you have a chemical called acetylcholinesterase that breaks down the acetylcholine so that it's no longer here, so that you can then relax. And so it's kind of a continuous sort of process that goes. So you can have certain conditions that interfere with that whole sort of process right there. And a couple that we think about in pediatrics is botulism. You can actually have tick paralysis, which is a very interesting condition. It really is caused by ticks and gives you paralysis, and the effect is right there at the neuromuscular junction. And myasthenia gravis. So myasthenia gravis is a specific condition where it's an autoimmune condition where you produce antibodies that attack the acetylcholine receptors there, so that even though your nerves are appropriately sending enough acetylcholine, they don't have enough spots to land on. And so that gives you weakness. A couple of clues for a neuromuscular junction issue is many of them are associated with a blurred vision. And I think that's because with vision, you're talking about really small muscles, whether it's your eyelids that'll kind of go down or the muscles involved in eye movement. They tend to be affected early and faster. And so someone who's not able to move their eyes really well can get double vision or blurred vision. You can have problems swallowing or even enunciating. You know, the swallowing, you know, consider that this issue can affect you know, all different muscles in your body. So you can have dysarthria, dysphagia, and you can have decreased reflexes. Reflexes can be normal. In many cases they are, especially early on, or they can be decreased. And to diagnose this, we typically use a nerve conduction study, and we that should say with. Nerve conduction studies are also typically done with what's called an EMG, where you're assessing both the nerve as well as the muscle. Specifically to test for myasthenia, there's something called the Tensilon test, and you can also do serum antibody tests, where you're looking for that antibody that causes interference right there to kind of disrupt the whole system. And lastly, you can have problems with the muscle. I'll just kind of give you a couple. You can have inflammation, which is either due to infection. There's some what we just call inflammatory myopathies, or you can have muscular dystrophy. Common signs for a muscle problem for weakness is muscle pain. If it's an inflammatory myopathy, kind of like what we call dermatomyositis, you can have characteristic skin lesions or systemic symptoms. Other parts of your body getting affected that clue you in to this might be an inflammatory myopathy. If it's a muscular dystrophy, you kind of have a chronic worsening weakness. So at some point it started and kind of gradually getting worse or involving more parts of the body. In most cases, it involves more what we call proximal muscles. And so kind of like your larger muscles, your legs and your arms, more than your fingers or your eyes. And to diagnose this, we do lab studies to look at a muscle breakdown or muscle function, sometimes genetic studies if indicated. And we can also do a nerve conduction study with the EMG to help diagnose this. All right, so going back to the case that we have, we want to make sure this is not weakness that caused the fall before we say it's a mechanical fall. And we have our differential diagnosis here, and this is just a review of the history of the present illness as well as the exam that we had. So let's go back into the room to see the patient because it feels like we might have a couple more questions to ask or exam parts to review to help us, you know, get back to our differential. And I'll give you it right here. That so we go in and we ask the ask the patient a couple more questions about what happened with the fall. Has it happened before? Have you been feeling weakness at certain times of the day? And this is what we get for our additional history. She actually does say that she's been feeling a bit weaker than normal after exercising or after she's had a very active day, but just thought it was normal. She also says that she's been having a bit more difficulty walking upstairs than in the past, but again, thought it was normal. Maybe she hasn't been as active. And so that's additional stuff that we got when we asked more specifically. So now we repeat the exam. One of the things that I like to do when I'm examining someone with the possibility of weakness, I don't always do it, but sometimes I do, is, believe it or not, we do squats right there in the office. And so I do it with them. And so I'm standing and I tell them just follow along with me, and I'll go down and I'll go up, and I'll go down and I'll go up. and I do it a couple of times. I actually don't work out that much. And so probably by around 5 squats, maybe I'll do 10 and I'll get tired. And I think most people, especially healthy adolescent teenagers, should be able to keep up. But what we noticed for this patient is that she was not able to keep up. After doing 3, she was done. She just physically could not do it. And she was actually a bit surprised because she doesn't typically do squats, but thought that she'd be able to do more. And also notice ptosis. So ptosis is the eyelid lag, unsustained up gaze. So what you do is I asked her to put my finger in front of her face and asked her to look up and just keep looking up at my finger. And I held it up there. So she's looking up continuously. And gradually after about 30 seconds, she can't do it anymore. The eyelids start drooping, and not just drooping to the normal level, but they almost close. And she has to do this to open them back up. And it's not even a joke. That's really what's happening. So based off of that, let's go back to our list here. And again, I'm just gonna kind of speed up the process. I'll now put my attending hat back on and not make you guess what I'm thinking. I'll just tell you what I'm thinking. Differential diagnosis for weakness. Could it be a brain problem based off of the additional information that we have? I don't think so. Could it be a spine problem? I don't think so. Could it be a peripheral nerve problem? Not likely. What actually, so sorry, coming back, not likely, but it's possible. But we're really left with 3 areas: peripheral nerve, neuromuscular junction, or the muscle. It really can't be the brain based off of what we're saying. It really can't be the spine. It's one of these 3 things. And the emergency department is waiting for recommendations from us. So we go ahead and say, you know what? This is what we'd like you to do. You don't need to image the brain or the spine because the problem is not there. We've localized it away from there. But we like testing for thyroid function, because that can affect your muscle to give you weakness. We like CK, which is creatinine kinase, which is a chemical that lets you know about muscle function. We'd like a complete metabolic panel, which again will tell us a bit more about muscle function. We'd like inflammatory studies, and that's going to look for anything that can cause inflammation of the peripheral nerve or the muscle. And specifically, you want to look for autoantibodies against the acetylcholine receptor, to look and see if there's a problem at that neuromuscular junction. And of course, we often get toxicology, and we want nerve conduction study as well. The ED was able to do all of this in record time, and these are the results. She actually tested positive for autoantibodies against acetylcholine receptor antibodies. Sorry, toxicology, I meant to say that was toxicology, and all other tests were normal. The nerve conduction study that we did actually showed signs consistent with myasthenia gravis, and so that is our diagnosis. And we tell her, and she's very busy looking up what myasthenia gravis is on her tablet right there. So I wanted to talk a bit about myasthenia gravis, but in the interest of time, and since I already kind of mentioned it a bit, I'll kind of go through a bit of things. You guys can read this slide here that's kind of giving you the basics. I talked about that as well as the clinical presentation. The most important thing to remember about myasthenia gravis is it gives you fluctuating muscle weakness. The reason it gives you fluctuating muscle weakness is because when you have that initial sort of release of, so if you look at this diagram, for normal muscle contraction, you have the initial release of the acetylcholine and you have your receptors. In this case, where it's blocked, when you have that initial release, you have transmission, but it's sort of reduced. So you're not getting the full strength. And the more that cycle is repeated, it kind of gets weaker and weaker. So the classic story is someone who is fine in the morning, but after a long active day, that's when they're tired. Someone who, after exercising, they're tired or weak. So this girl, after going on the stationary bike, she had used up all her acetylcholine reserves, and the moment she started walking, the legs just couldn't take it. She fell. That's what happened. And you can also have, again, because what I mentioned with the small muscles, you can have ocular problems. You can have dysarthria, dysphagia. And again, this diagram kind of shows you how it goes. And diagnostics, that's the testing that we did. We also look at the chest because you can have, these are associated with thymomas. So we often do a chest CT or MRI, although that's not something that's sort of an emergency. And the treatment is you get an acetylcholinesterase inhibitor. Remember I told you that when you have your acetylcholine that, so going back to this diagram, you have your acetylcholine that kind of goes there. And in this case, it's inhibited, but it goes and binds to the receptor, and you have acetylcholinesterase that breaks it down so that it's not sustained. Well, so what we do is to treat myasthenia gravis, you inhibit the acetylcholinesterase so that the acetylcholine actually stays for a longer time there. So even though there are fewer receptors available, you kind of still get the transmission that you need. And because this is an autoimmune disorder, the treatment is immunosuppressive therapies, several different ones, and also taking out the thymus if there is thymus enlargement. It is a chronic but treatable disease. It's kind of like once you have it, but once you're treated, most people respond really well, and most people have sustained remission of symptoms with full functional capacity. So the teaching points that I hope you guys, everybody got from this, from a neurology standpoint is number one, always develop a broad differential diagnosis list for starters, and then gradually narrow it down, kick things off the list so that you're left with what is the cause. And also in neurology, it's very important to localize the lesion. So think of the whole pathway of what happens for something to happen, or all possibilities, and then you localize, you kind of identify where is the problem to determine what test you want to do. And definitely it's important to repeat a history or exam when needed. In this scenario, we went in the first time, got some information, stepped outside, thought about it, and said, we need to go back in. And we did that, and that's what gave us the diagnosis. So advice to future physicians, I hope most of you who are out there do end up becoming physicians. I like to say, make the journey to medicine your own. The journey is just as important as the destination. Yes, you want to be a child neurologist at the end, but you want to make sure that every step of the way was something that was useful to you as an individual. Everybody has their own story. Make your your journey to medicine a part of that story for you. I hope this was really useful. Thank you everybody for attending. Thank you for the questions. I apologize if there's questions that I didn't get to that are pressing. Contact information. So of course I have my official contact information. For now, just given the nature of this talk, if you do have any kind of questions or whatever, I'm on Instagram. That's how you can get a hold of me. If it's something that needs to be taken off the social media to a more formal platform, we can do that as well. And I'm open to any questions. I don't know, moderators can kind of chip in and tell me, because right now it is 7:58. How much time do we have for questions?
It's up to you. You can answer as many questions as you'd like.
Okay. All right. So what I'll do then is I'm scrolling at the questions. There are a lot of thank yous. You're welcome. I think I do academic medicine, and for those of us, not just in academic medicine, but doctors, we love teaching. So you're welcome. I'd love to do something like this again, look at a different body system. But yeah, if there's questions, I'll try and answer them. Maybe we'll go for, some 10 minutes. And if people have to go or as time's winding up, then we'll kind of get it close to it. So, all right. So let's see questions. Someone said they like the elimination of the differential diagnosis. I'm glad you love that. And if anyone ever gets an opportunity post-COVID to really kind of shadow me around with me, I do that all the time with myself and with everybody else. What is the possibility of seizure just disappearing one day? That's a great question. You may be surprised to know that most children who have seizures have it one time and it never comes back. It can be provoked in the setting of a fever or other conditions, or sometimes it's completely unprovoked. The child's brain is continually developing, and sometimes things just don't connect right, and they have a seizure, never have another one again. So a child who has a seizure will do the EEG test, and we'll often also do a brain MRI. If all that's normal, we don't start any medicine. We tell parents, if this never happens again, I never need to see you again. If it happens again, come back to see me. That'll mean it's epilepsy, and we need to do something to treat that. Let's see, what proportion of the cases that you see are acute onset? If you mean weakness, I'll say majority of the cases that I see of weakness are acute onset. And that's only because, so a big difference between child neurology and adult neurology is that children are taken care of by their parents. Parents will take their child in to see a physician the first moment something is abnormal, but adults will often kind of wait and kind of hold things. And so for kids, you usually get to diagnose things very early, not always, but usually. And so it's still at that acute stage, even if it'll be a chronic later on. Whereas sometimes with adults, they come in and they tell you they've been having weakness for 3 months or 6 months. And then, it's a chronic condition you have to figure out at that point. Can vasovagal syncope be chronic? Yes, it can. Um, a lot of people will grow out of it. So if it's vasovagal syncope related to like blood is a common one, a lot of people at a certain age it just stops happening. But there's some people where it's a lifelong thing. And again, the recommendation there is if you know that's what it is for you, then avoid the blood or whatever the trigger is. So someone asked how biomedical engineering influenced my practice of neurology. That's a very interesting question because and I'll just take a step back and talk about my journey into neurology and into medicine a bit. When I was in undergrad at Yale doing biomedical engineering, I thought I wanted to do medicine as an option, but my mind was still wandering. I thought I might want to do engineering as well. For my senior research essay and senior research project, which we're required to do, I learned about the topic of brain-computer interfaces, which is a big thing. Just to give you a clue about how old I am, this was 20 years ago. So 20 years ago, I was doing research on brain-computer interfaces, and that gave me a love for neurology specifically. And in the research job that I worked for 3 years doing research after college, before medical school. I worked with several physicians who were either adult neurologists or child neurologists, and that got me wanting to do medicine. And I applied to medical school, got in, and ended up doing neurology. And I tend to think one way that it influenced me is that to a certain degree, I think of the nervous system almost like a machine. A common thing I tell patients and parents is think of the nervous system that neurologists deal with as like the hardware of a computer. That's what we deal with. And so I do find that, as an engineer, I'm attracted to engineering principles, and that's not too far off from some of the neurology and neurological principles that we apply. So I think that's how it's influenced it, and it's also influenced some of the research that I do. All right. So someone asked, can I speak about my role as a professor and what attracted you towards becoming an educator? I think being an educator is something that you just need a passion for and that you love. Once you've completed your medical school, once you've completed your residency and you're an attending, you can choose to go into private practice, not do any teaching at all. But what tends to happen is people who enjoyed the process of learning and also the process of teaching, because as a resident, you'll be both learning and teaching, they tend to fall into academic medicine to get that opportunity to teach. I think for me, and I was mentioning to the moderators earlier that one of the downsides of COVID, I know for those of you who are pre-med, who like being in hospitals, you're not getting shadowing opportunities. For us in the medical field who love teaching, we also feel deprived of that. When I'm doing my sessions in the hospital right now, it's great that I have the residents and I have the fellows to teach, but I kind of miss the medical students, and I also kind of miss the pre-meds, teaching to each and every level. So it's a passion for teaching that gets us into that. And my role as a professor, in many places, many institutions that have a freestanding hospital that have an academic affiliation, as an assistant professor or professor, it means that a lot of the teaching that you do goes towards the medical students from that institution, and also means that you have available some of the educational resources from those institutions. So I'm very fortunate to be in a system where I have clinical resources through our hospital, as well as educational resources through a large university as well. What classes would you recommend for people in college that will help in med school and the medical field? Well, certainly for medical school, you need to do the required courses, which I don't know, it's been a while for me, but there's certain required courses that you'll need prior to applying to medical school. So I recommend that. Beyond that, I'd say do whatever your passion is. Many people have a passion for biology or chemistry, so that's what they do in addition to being pre-med. Some people have a passion for English. My boss actually, who's one of my favorite people who I worked with, so when I said I worked at Georgetown before I went to medical school, one of the professors I worked with is currently my boss right now. It comes full circle. So he was, I believe, a history major. And so he did history because that was his passion, and he can talk your ear off about history. But he did the pre-med courses, and he's now a physician. Another one of my favorite mentors in residency was an English major. So, you know, I think it's important to be well-rounded. So you have to do well in your science courses. But if you have a passion for something else, take the opportunity in undergrad to do that. Because when you're in medical school, you are focused on one thing solely, and that's medical education. Any advice to someone who has vasovagal syncope in response to blood? I think I'd mentioned that in general, avoid whatever that trigger is. As a professor, any advice for international students who are already doing undergrad in US? You know, to be quite honest, advice about how to go around to be a medical doctor. You may find better resources if you have a medical school advisory committee at your school, because there are very many specific details that unfortunately, I don't know, and I don't want to lead anyone down the wrong path. What is one of the hardest neurological cases to diagnose? That's a great question. So I'll say the medical cases that are the hardest to diagnose are those where the initial history doesn't give you a clue and the initial exam doesn't give you a clue. And there's very many varieties of that where, you know, whatever you thought it was at first is not it. So for example, this case, at first it seemed obvious that this was a mechanical fall. But once we gave it a bit of thought, turns out that it wasn't. So there are a lot of challenging cases like that, but off the top of my head, I can't think of what the most challenging case was. Someone says minor or double is something you also like, may or may not be related. Yeah, I think that's not a bad idea. I mean, I was an engineering major. Granted, it was biomedical engineering, but I had a passion for that. And I said, you know, I'm taking the pre-med courses as well. All right, what would your advice be to students who do not have much research experience? So if you're asking about advice to someone who's an undergrad who does not have research experience and is applying to medical school, I'll say, you know, if first of all, if you're going to do any research, make sure it's something that you're passionate for and not something which ends up being like a chore. If you didn't have that opportunity, then you can still apply to medical school. There are a lot of things that they look at in medical school for applicants. So you can still apply. It might mean that you might have to be particularly strong in other areas. Some people take some time off to do research, kind of like I did. I took 3 years. You don't have to. Many will do just 1 year or none. But ultimately, like I said, your path is your own. If research is not your thing, then you don't have to do something that's a chore. But at the same time, if you look around or ask around, you might find someone who's actually doing some research that you're interested in. What would your advice be for students who don't have much shadowing experience apart from online right now, but have some research experience? Again, your journey is going to be your own. There are many reasons why you might not have any shadowing experience. But as long as when you're doing your application, you know who you are, you know what your strengths are, you know what you bring to the table. And of course, talk with any mentors who know you personally to help you to sort of customize or personalize your application. If you do that, I think you'll be in a good footing. I had exactly zero shadowing experience at the end of my undergrad. And in the 3 years that I was doing research, I think I shadowed one of my colleagues like twice, like a total of 2 clinics, and that was it. Some people have the opportunity to do a lot of shadowing. You know, everybody's journey is going to be different. Let's see what else. I'm in India. It's so hard to get shadowing experience because there's hardly any concept of internships. And yeah, again, I'll just say don't focus so much on what you don't have and what you can't do, but focus on what you have done and what you can do. And talk with someone who knows you personally as a mentor, who can kind of guide you further along the process. Someone else is asking, how do you feel the work-life balance is in neurology? Work-life balance is important in any career, especially so in medicine, because when you're at work, sometimes it can be stressful, you know, where you're talking about life or death. You know, I'm talking to children who have strokes and brain tumors and that kind of thing. And it's important to have some time to go home, be with your family, be with your friends, and have fun. And neurology, especially with academic medicine, allows that. I don't think my work-life balance is off. And I put my Instagram right there. If you actually look at my Instagram, I talk a bit about some of the things that I do in my off time: gardening, cooking. I might even put some vacation stuff from there. No vacations this year, but vacations from before. So neurology really affords a very great lifestyle. Some care more about patient care experience. It really depends on the med school. You're right. Medical schools are different. Admission committees are different. That's why it's good to have a mentor who kind of knows if you are particularly interested in one medical school over another, what they might think that medical school values. All right, what I'm going to do is, in the interest of time, I'm going to take maybe 2 more questions. I'm just going to look through and see if there's something that seems to have been a common question before wrapping this up. So 2 questions that I'll combine into one. Someone's asking if I would recommend a combined BS-MD undergrad program, and someone else is asking, is the lack of research detrimental when applying to medical schools? So the BS-MD undergrad program is a decision that you have to make knowing yourself, in discussion with the mentor who knows you. There are pros and cons to doing that. I don't want to sit here and say, I didn't do that, and so do it the way I did it because the way I did it is best. No, your journey is going to be your own. And the question about the lack of research detrimental when applying to medical school, not specifically. What you have to be able to do is to turn any weakness into a strength, and also amplify any strength that you have. Everybody has a reason as to why they might not have had the opportunity to do research or not had the opportunity to shadow. Everybody's story is different. So you just have to make sure that you highlight what your strengths are. All right, let's see, last question. Oh, actually, this is a very nice question. Were you ever unable to diagnose something? The answer to that is yes. And actually, I'll say that happens a lot in neurology. The reason for that is sometimes it's most crucial to identify what something is not rather than what it is. So for example, if this patient who came in with the fall, if 100% of our testing was normal, including the tests that we did, then our diagnosis would ultimately say that it was either a mechanical fall or something we don't know, but at least we know it's not something to do with the brain, spinal cord, nerves, neuromuscular junction, or the muscle itself. So there are many, I'd say, milder cases that we see where if something happened, someone had a fall or someone had something happen, but by the time you see them, they're 100% fine. We're not going to give them $1 million workup and all sorts of tests, but we'll tell them if it happens again, come back and we'll do some more tests. And sometimes, especially depending on the kind of institution you're at, sometimes you do get very challenging cases where a patient is very sick or ill and you're not able to actually figure out what exactly is going on. And sometimes that's part of the challenge. And some people don't like neurology because of that. And some people like myself do like that challenge of you do have to think really hard and figure out what's going on in the patient. Okay. I do want to thank everybody. I see more questions coming in, but unfortunately, with respect to everybody's time, I will sort of say that's it for now. I really enjoyed doing this, both presenting the case as well as answering these questions later on. Definitely with the web shadowers, if they're having more of this in the spring, I'd love to do it if they'll have me. And so I don't know if the moderators have any way they want to wrap this up.
Thank you so much, Dr. Mbwana, for such an interesting presentation. It was so informative and we all learned so much.
All right, you're welcome. My pleasure.
Everyone, make sure to check out his socials. His Instagram is itsfriday_MD.
Additionally, thank you all so much for attending. The Google form has now been posted in the chat, and fill it out within the next 30 minutes, please, for us to receive your verification. Again, thank you so much, Dr. Mbwana.
All right, my pleasure. You guys take care.
We'd love to have you next semester.
Oh, absolutely. Just let me know.
Thank you.
All right, take care.
Thank you.
Bye.
We'll stay in